A heart attack doesn't always begin with dramatic chest pain, obvious symptoms, or a warning that something is wrong. Sometimes, the person who appears perfectly healthy can be carrying cardiovascular disease silently for years, and that is what makes heart disease so dangerous. You may exercise, look fit, maintain a normal weight, and even have what appears to be normal routine blood work, yet still have plaque developing inside your arteries. The important question isn't simply, do I feel healthy? The better question is, how healthy are my arteries and how much cardiovascular risk am I carrying? Today we're going to explore why heart attacks can happen unexpectedly, how plaque can remain hidden, why a blockage doesn't always cause symptoms, what actually happens when plaque suddenly ruptures, and what steps can help identify cardiovascular risk before a major event occurs. Let's start with one of the most important arteries in the heart, the left anterior descending artery, commonly known as the LAD. You may have heard it described as the whiteout maker, because a severe blockage in this artery can compromise blood supply to a large portion of the heart's left ventricle, which is responsible for pumping oxygen-rich blood throughout the body. But the nickname can sometimes create the wrong impression. A heart attack is not necessarily caused by one specific artery, and not every LAD blockage causes sudden death. The real issue is that certain locations and patterns of disease can be particularly dangerous. Your coronary arteries are not simple rigid pipes. They are living tissues that respond to changes occurring inside them. Over many years, cholesterol-containing particles, inflammatory cells, connective tissue, and calcium can accumulate within the artery wall and form atherosclerotic plaque. And here's where the story becomes surprising. An artery can develop significant plaque without immediately becoming severely narrowed in the center. Instead of simply growing inward, like something blocking a pipe, the artery wall can remodel outward in response to plaque growth. This is sometimes called positive or outward remodeling. Imagine a tunnel that becomes thicker from the outside while its inner passage remains relatively open. From the outside, disease is developing, but the opening where blood flows may remain large enough that blood flow appears normal. This helps explain why someone can have significant coronary artery disease without experiencing classic symptoms. You may climb stairs, go for a walk, or perform everyday activities and feel completely normal. Your heart can still receive enough oxygen during those activities, at least for the moment. That doesn't necessarily mean the artery is disease-free. It means the disease may not yet be restricting blood flow enough to produce noticeable symptoms. This brings us to one of the most important misconceptions about heart attacks. Many people assume that an artery must gradually narrow until it becomes almost completely blocked, and then the heart attack occurs. That's one possible pathway, but it is not the only one. In fact, many acute heart attacks occur when a previously existing plaque suddenly becomes unstable and ruptures. Picture a plaque as a small area within the artery wall, containing cholesterol, inflammatory cells, and a fibrous covering. Some plaques are relatively stable, while others contain a larger lipid core and a more fragile protective layer. When an unstable plaque ruptures, material inside the plaque becomes exposed to the bloodstream. Your body recognizes this as an injury and activates platelets and clotting mechanisms. A blood clot can then form rapidly at the site of the rupture. If that clot becomes large enough to significantly obstruct blood flow, the heart muscle downstream may suddenly be deprived of oxygen. This is a major mechanism behind what doctors call a type 1 myocardial infarction. The frightening part is that the artery may not have been severely narrowed before the rupture occurred. Someone might have had a plaque that was only producing a moderate narrowing, yet the plaque itself was biologically unstable. So the danger isn't always simply, how narrow is the artery? Another question is, what is the condition of the plaque? This is why the old plumbing analogy can be misleading. Cardiovascular disease is not simply about finding the biggest blockage. It's about understanding the biology of the artery, the characteristics of plaque, inflammation, clotting, blood pressure, cholesterol, metabolic health, and many other factors. Now, another mechanism we need to understand is called a type 2 myocardial infarction. Unlike a classic plaque rupture, a type 2 heart attack occurs when the heart's oxygen demand exceeds the oxygen supply available to the heart muscle. This can happen in situations such as severe anemia, very low blood pressure, significant oxygen deprivation, rapid abnormal heart rhythms, or extreme physiological stress. Imagine a highway that normally carries enough traffic, but suddenly experiences an enormous surge in demand. Even if the road hasn't completely collapsed, the system can become overwhelmed. The same principle can apply to the heart. If the heart is beating extremely fast or working under severe stress while oxygen delivery is compromised, injury can occur. This is why cardiovascular health isn't just about cholesterol. Blood pressure, blood oxygen levels, heart rhythm, anemia, diabetes, smoking, kidney disease, and overall metabolic health can all influence cardiovascular risk. Another commonly misunderstood issue is the relationship between symptoms and the degree of blockage. Many people assume that if an artery isn't severely narrowed, it cannot be dangerous. But symptoms such as stable angina generally become more likely when a narrowing is severe enough to limit blood flow during increased demand, often around the range of 70% in certain coronary arteries. But there is no universal blockage percentage that predicts whether someone will or won't have a heart attack. A person can have a severe stable narrowing and experience symptoms during exercise, while another person can have a smaller but unstable plaque that suddenly ruptures. This is why the statement, "I'm fine because I don't have chest pain," can be dangerous. Absence of symptoms doesn't guarantee absence of disease. At the same time, we shouldn't create unnecessary fear in healthy people. Not everyone needs advanced heart scans simply because they feel well. Screening decisions should be based on individual cardiovascular risk and discussed with a qualified clinician. So how can you reduce the chance of developing dangerous plaque in the first place? The foundation remains surprisingly familiar. Control blood pressure, avoid smoking, maintain healthy blood glucose, manage cholesterol, stay physically active, maintain a healthy body composition, sleep adequately, and eat a predominantly heart-healthy diet. These may sound less exciting than a secret scan or miracle supplement, but they have enormous importance. High blood pressure can damage the inner lining of arteries over time. High levels of atherogenic cholesterol particles, particularly LDL cholesterol, contribute to plaque development. Smoking accelerates vascular injury and increases clotting risk. Diabetes and chronically elevated blood glucose can damage blood vessels and increase cardiovascular risk. Physical inactivity can worsen blood pressure, insulin sensitivity, body composition, and overall cardiovascular fitness. These risk factors often work together rather than independently. And this is where exercise becomes particularly interesting. Regular physical activity doesn't simply burn calories. It can improve blood pressure, insulin sensitivity, lipid profiles, cardiovascular fitness, and the ability of your body to handle physical stress. Some research also suggests that regular exercise can promote the development and function of collateral blood vessels in people with coronary disease. These collateral vessels are essentially alternative pathways that may help deliver blood around an area of obstruction. Think of them like side roads developing around a congested highway. But we need to be careful here. Exercise does not guarantee that your heart will build enough collateral circulation to protect you from a heart attack. You cannot exercise your way out of every coronary blockage, and someone with known heart disease should follow an appropriate exercise plan rather than suddenly beginning intense workouts. This is where different forms of exercise can play different roles. Moderate aerobic exercise, sometimes described as Zone 2 training, can improve aerobic capacity and cardiovascular fitness when performed appropriately. Higher intensity intervals can also improve fitness for people who are medically cleared and properly conditioned. But you don't need to begin with extreme workouts. Walking, cycling, swimming, jogging, and other regular aerobic activities can provide meaningful cardiovascular benefits. The most important exercise is often the one you can perform consistently. Now let's talk about testing, because this is where many people become confused. A standard blood test can provide important information about cardiovascular risk, but blood tests alone cannot directly show you how much plaque is sitting inside your coronary arteries. A lipid panel can tell you about cholesterol and triglycerides. Blood glucose and HbA1c can provide information about blood sugar. Blood pressure tells you about another major risk factor. These are extremely valuable measurements, but they answer different questions from an imaging test. One test that may be used to assess coronary artery disease risk in appropriate patients is a coronary artery calcium scan, often called a CAC scan. It uses CT imaging to detect calcium deposits in the coronary arteries. A calcium score of 0 can be reassuring in many appropriately selected people, although it does not mean that cardiovascular risk is literally 0, and it may not detect non-calcified plaque. On the other hand, a higher calcium score generally indicates a greater burden of calcified coronary plaque and can help refine risk assessment. But the number isn't simply a universal good or bad score. Its meaning depends on your age, sex, risk factors, symptoms, and overall clinical picture. Another imaging technique is coronary CT angiography, or CCTA. Unlike a calcium scan, kinetic angiography can provide more detailed images of the coronary arteries and may identify both calcified and non-calcified plaque, as well as narrowing within the vessels. It can therefore provide information that a calcium score cannot. However, it involves contrast material and radiation, and it isn't appropriate as a routine test for every healthy person. If you have symptoms or a specific cardiovascular risk profile, your doctor may determine that a particular test is appropriate. The key lesson is that more testing is not always better. A medical scan should answer a useful clinical question. Now let's discuss blood pressure, because this is one of the most underestimated drivers of cardiovascular disease. You can feel completely normal while your blood pressure is gradually damaging the walls of your arteries. High blood pressure often has no obvious symptoms, which is why it is sometimes called a silent risk factor. Over years, elevated pressure can contribute to arterial damage and increase the workload placed on the heart. Measuring your blood pressure is therefore one of the simplest ways to learn something important about your cardiovascular health. Blood sugar is another major piece of the puzzle. Persistently elevated blood glucose can damage blood vessels and is associated with increased cardiovascular risk. You don't need to wait until you develop obvious symptoms to pay attention to your metabolic health. Regular physical activity, a balanced diet, maintaining a healthy weight when appropriate, and medical treatment when necessary can all help manage blood glucose. And then there is cholesterol. Cholesterol itself isn't the enemy. Your body needs cholesterol to make hormones, cell membranes, and other essential substances. The issue is the balance and concentration of different lipoproteins that transport cholesterol through the bloodstream. LDL-containing particles play a major role in atherosclerosis, and reducing elevated LDL cholesterol is an important part of cardiovascular prevention for many people. If you have a strong family history of premature cardiovascular disease, unusually high cholesterol, diabetes, hypertension, or other risk factors, it is especially important to discuss your overall risk with your healthcare professional. Genetics can matter even when your lifestyle appears excellent. Some people inherit conditions that significantly increase LDL cholesterol or cardiovascular risk, and identifying these conditions early can make a major difference. Another important factor is smoking. If you smoke, Quitting is one of the most powerful things you can do for cardiovascular health. Tobacco smoke damages blood vessels, promotes inflammation, increases clotting tendencies, and accelerates atherosclerosis. And the benefits of quitting begin well before old age. The earlier you stop, the better, but quitting at any age can provide meaningful health benefits. Sleep also deserves attention. Poor sleep, sleep apnea, chronic sleep deprivation, and irregular sleep patterns can interact with blood pressure, metabolism, and cardiovascular health. If someone snores heavily, stops breathing during sleep, wakes repeatedly, or experiences significant daytime sleepiness, discussing possible sleep apnea with a clinician may be worthwhile. So why do seemingly healthy people sometimes have heart attacks? Because appearance is not an artery test. Someone can look fit while having high LDL cholesterol. Someone can be slim while having hypertension. Someone can exercise while still smoking. Someone can have normal routine blood work while carrying early coronary plaque. And someone can have no symptoms because their disease has not yet reduced blood flow enough to trigger them. This doesn't mean everyone should panic. It means we should replace assumptions with appropriate risk assessment. Instead of asking only, "Do I feel healthy?" ask, "What are my measurable risk factors?" Know your blood pressure, know your cholesterol profile, know your blood glucose or HbA1c when appropriate. Understand your family history. Don't smoke, stay active, eat a diet rich in vegetables, fruits, legumes, whole grains, nuts, and other minimally processed foods, while limiting excessive saturated fat, refined carbohydrates, sodium, and ultra-processed foods according to your individual needs. Maintain a healthy weight if possible, and don't ignore persistent symptoms. And if you experience sudden pressure, squeezing, or pain in the chest, especially if it spreads to the arm, back, neck, jaw, or comes with shortness of breath, sweating, nausea, or fainting, seek emergency medical attention immediately, rather than trying to diagnose the cause yourself. Heart attacks can present differently from person to person, and women and people with diabetes may sometimes have less typical symptoms. Ultimately, the most powerful strategy against heart disease isn't waiting for your body to send a dramatic warning. It's identifying risk early and addressing it before a crisis occurs. Atherosclerosis can develop silently for years, but that doesn't mean you're powerless against it. Blood pressure can be treated, cholesterol can be managed, diabetes can be controlled, smoking can be stopped, fitness can be improved, diet can be changed, sleep can be improved, and in selected people, imaging can provide additional information about coronary plaque and cardiovascular risk. The goal isn't to become obsessed with your arteries or undergo every possible test. The goal is to understand your personal risk and take sensible action while you still have the opportunity, because a heart attack may appear sudden, but the disease process behind it often develops over many years. Prevention, therefore, begins long before the emergency room. It begins with the ordinary decisions you make when nobody is watching. The food you eat, whether you move your body, whether you smoke, whether you monitor your blood pressure, whether you take prescribed medication, whether you sleep enough, and whether you take warning signs seriously. Being healthy isn't simply about looking healthy on the outside. It's about protecting the cardiovascular system that keeps you alive every second of every day. And the earlier you understand your risk, the more opportunities you have to change the story before a silent problem becomes a life-changing event.